We heard a little bit about coronary calcium already in the first two talks. I think Dr. Falk and Dr. O'Leary nicely outlined some of the issues related to atherosclerosis detection and where it may play a role. I just wanted to update you on some of the data that we now are seeing and why we've been making some progress, both with some of the issues that we've seen with IMT, including payors, as well as getting Category 1 codes for calcium scoring. So coronary calcified plaque is clearly just the tip of the atherosclerotic iceberg. John Rumberger made this concept fairly well known in the late 80s and early 90s. And over the past 20 years, coronary calcium has achieved substantial validation, but it still only represents a portion of the atherosclerotic plaque. If we use the iceberg analogy, about 20% of atherosclerosis is calcified and about 80% is not. So clearly the vulnerable plaque may be mixed, which it probably is, a little bit of calcium and a little bit of soft or fibrous tissue, or it may be all soft and it may not be represented by the calcified lesion. So coronary calcium is not going to necessarily represent the vulnerable plaque, but will, by its nature, represent the vulnerable patient. It will identify the person who has the disease. They have atherosclerosis. Coronary calcium is only coronary atherosclerosis. There has never been Mockenberg sclerosis demonstrated in the coronary arteries. There's never been another process associated with calcification of the coronaries other than atherosclerosis. There's been hypotheses, maybe vasculitis, maybe renal failure and medial calcification, but those have never been validated or demonstrated in autopsy. So for all intents and purposes, if we detect calcium in the coronaries, be it by fluoroscopy in the cath lab, or by a chest x-ray, or by a CT scan, we have a patient with the disease. They have atherosclerosis. The more calcium they have, the more total plaque they have. So the Titanic going downstream sees an iceberg floating off its hull. It knows that it's going to have a problem based on what's below the surface of the water, not what it sees above. It didn't say, oh, let's send some divers below the surface of the water to see if we're going to run into trouble or not. They knew they would. And the same thing has to be applied to coronary calcium. Not based on one study or two studies, but on more studies than we could give in this whole American Heart Association symposium. There's been hundreds now of studies. There's been 2,000 publications on coronary calcium. So I'll try to summarize a few of the key ones, but keep in mind what I'm giving you as far as the data goes with coronary calcium is also just the tip of the iceberg. So where's the data that a positive calcium scan indicates incremental risk and theoretically may alter the therapeutic goal? Because remember, the National Cholesterol Education Panel, 2001, said that coronary calcium scanning could be used to risk stratify patient and alter the therapeutic goal. 2001. Now, I don't have any data that goes before 2001, so this was forward thinking by Scott Grundy and his colleagues, but subsequently has been validated by a number of trials. So I'm just going to take you through the largest of those studies. So here's the first large study ever published, Leslie Shaw, Paolo Raggi, 2000, published in Radiology in 2003. This is 10,377 patients, a large trial. And basically all it said was, in blue, the more coronary calcium you have, the more likely you are to die over the next 5 years. No calcium, virtually no mortality, and a high calcium score, mortality that exceeded 12%. So a pretty big jump in mortality, and as you can see, it was not only independent of cardiac risk factors, but incremental. In other words, diabetes adds a 3-fold risk, and calcium adds a 10-fold risk, and having diabetes and coronary calcium in a high number added a 30-fold risk. That they're incremental risk factors. They add to each other, which is very important because what we've not been able to find with biomarkers and what we've not been able to show well enough, I don't think, with carotid IMT is that it's incremental in its risk prediction. And that's a problem, because if we can't add to what we already know and improve upon something as simple as the Framingham model, albeit with all its shortcomings that we heard about tonight, then we have a problem in justifying its expense. Coronary calcium in every large published trial, adds incremental value to risk factors. Not in one trial, not in a few, in every published study. Here's another large study called the St. Francis Heart Study. 4,903 patients, population-based study, followed for 4.3 years. So 5,000 patients, 4-year follow-up. And it showed a very simple thing. The more calcified plaque you have, the worse your outcomes. These are hard endpoints, MI and death. The higher the calcium score, the more likely you are to suffer a heart attack or die with a cardiac event over the next 4 years. A score of 0, a very safe place to be. Event rates were 1 in 1,000. 1 in 1,000, that's pretty low, 0.1%. When did we cross that magical threshold of 2% per year, 20% 10-year risk? And the answer was a score of 100. Calcium score of 100 invoked a 10-fold increased risk after multivariate analysis. It improved the ROC, it improved the C statistic, it was a 10-fold predictor of future cardiac events. And it was so robust that it was met with incredible skepticism. Incredible skepticism. For those of you who remember around the mid-2000s or the early 2000s, it was incredible the amount of pushback that was being given based on this being too good to be true. We can't be 10-fold predictive of future events because CRP in the best of hands was 2-fold predictive. And carotid IMT in most of the studies is 2-fold or 3-fold predictive. And being a diabetic is 2-fold more likely to suffer an MI. This is 10-fold? Not possible. This is more than what we get with an abnormal nuclear test. Think about that. A moderate ischemic burden on nuclear is 7-fold increased risk of future events. This is 10. So this is too good to be true. So let's look for additional validation. Well, this is an observational study, so it's limited. I published this. The merits is that it's large, 25,000 patients, and that it's long, 12-year follow-up. And what did we get for a score of 100? 10.4. So St. Francis Heart Study, 9.9. This is death, heart event, 10.4. You're 10.4 times more likely to die with a calcium score above 100 than a lower score. Does that hold up in other prospective studies? Here's an NIH-sponsored study from the Cooper Clinic. Observational study, 10,800 patients. And remarkably, a score of 100, seen here, 9.7-fold predictive. 10-fold predictive if your calcium score is above 100 for having a heart attack or death over the next few years. So your short to intermediate risk of having an event, long-term risk in my study, was 10-fold. Let's see the rest of the data. Alan Taylor, who's presenting other data now on carotid IMT, did a study with coronary calcium called the PAC study. 2,000 patients, mean age 43. Coronary calcium was associated with a 12-fold increased risk for incident coronary disease after controlling for the Framingham risk score. He concluded that in young asymptomatic men, these were active military personnel, theoretically pretty healthy people, the presence of coronary calcium provides substantial, cost-effective, and independent prognostic value in predicting incident heart disease that's incremental to measured risk factors. So it's incremental, it's substantial, and it's cost-effective. Nice adjectives to be associated with a diagnostic test. Let's see if the rest of the data holds out. This is from Dr. Anand. This is asymptomatic diabetics. Primary prevention, no known MI, stroke, or claudication. 510 asymptomatic diabetics. You can see the area under the curve for Framingham score, 0.60. UK-PDS score in diabetics increased the area under the curve significantly to 0.74, and coronary calcium increased the risk to 0.92. The odds ratio of if you had a score above 100 was 10.1. So far we have 9.9, 10.4, 9.7, 11, and 10. All almost identical, despite different populations and different continents being presented. The data continues to remain very similar. This is another study from Germany. This is from Dr. Becker, looking at about 900 patients, and again, incremental risk prediction, the area under the curve is improved, the predictability for who's going to have a future MI or death gets better with the presence of coronary calcium. It's atherosclerosis. It's not hard to understand that if you have atherosclerosis, you're more likely to have an atherosclerotic event. If you have hypertension, you may or may never not develop atherosclerosis. So hard to have an atherosclerotic event if you're a hypertensive who doesn't have atherosclerosis. Here's the area under the curve for the coronary calcium score, the Agatston score. And you can see it's much improved over the European ESC score, the ProCam score from Germany, or the Framingham score. Here's another study where coronary calcium was tenfold predictive. A score of 100 was tenfold worse than a score of 0. And in this study, you can see the curves separate. They compared this to stress echo for new wall motion abnormalities, and coronary calcium was predictive, tenfold predictive. Wall motion abnormalities were not predictive of future events in this trial. So the data finally gelled, and now CMS is giving us Category 1 codes for coronary calcium, not based on any of the previous trials that I showed you or others that we didn't have time to discuss, but based on this trial. $100 million investment to determine, and you heard about this a little bit from Dr. O'Leary, $100 million investment called the MESA trial to figure out which test is best. Should we be doing calcium scoring? Should we be doing MRI? Should we be doing carotid IMT, ankle brachial index, blood works, genetic testing, advanced lipoprotein testing? And when you looked at a multivariate analysis, the only two tests that remained in the model at all were coronary calcium testing and carotid IMT. And I'll show you the relative difference. We saw some of that already from Dr. O'Leary. But remarkably, $100 million later, what did the NIH come up with as their answer? A score of 100 is 10.3-fold predictive. Right? We all could have saved them $100 million by saying, just look at the available data. It's remarkably consistent. This is a population-based study. This is multi-ethnic. This is Asian. This is Hispanic, African American, and Caucasian, and you are 10.3 times more likely to suffer a heart attack or death if your calcium score was over 100. More calcium, more events. Low score, 0 score, virtually no events. So remarkably consistent with the prior data. Here's the carotid IMT and coronary calcium data. This is for coronary events. And you can see carotid IMT was independently predictive for future events. Twofold predictive, very similar to many of the other trials that have been discussed tonight. Coronary calcium, 10.3-fold predictive. So we have some relative power here to look at these different tests and how they predict future events. Now, the issue is probably not which subclinical atherosclerosis test to get, because I could easily say if you're under age 45, I would favor carotid IMT, and if you're over the age of 45, the data would favor coronary calcium, and there's reasons for that, both biological as well as from the epidemiologic studies we've discussed. But the question doesn't come down to which subclinical measure, it's which biomarker should we measure. Should we be measuring LPPLA2? Should we be measuring C-reactive protein? Should we measure MMP? Should we be measuring interleukin-6? And at least when they tried to measure 11 of them, the answer was none of them work. So this is New England Journal of Medicine 2006. You can see the major cardiovascular event curves here with biomarkers, without biomarkers. This was 10 different biomarkers put together, including BNP, C-reactive protein, D-dimer, homocysteine, urine albumin, all different things that you might imagine should work, and they didn't work at all. They didn't work at all. The area under the curve is identical with biomarkers and without biomarkers. So at least large epidemiologic trials, this is the Framingham Heart Study, the study that proved that cholesterol is a bad thing, proved that biomarkers are not a good thing. So that's what we know today. Biomarkers don't work so far. Well, hopefully we'll get new data in the future, but they don't seem to risk stratify and separate out the area under the curve. IMT works, and coronary calcium works. So far, at least with C-reactive protein, which we hear the most about, has not added to the ROC curve for prediction of cardiovascular events in any trial ever published. In any trial ever published. It has not improved the predictability. So that's a little disappointing for a test that's so ubiquitous and so widely propagated, yet doesn't have data to support its clinical use so far. The latest piece of the puzzle comes from Germany, the Heinz-Nixdorf recall study. Probably, in my mind, the most important clinical trial that we've seen so far because it's unbiased by the results. I say that because the participants did not know what their calcium score was. So in MESA, we told the participants, you have a lot of coronary plaque, you better treat yourself. Now they still had events 10 times more than the groups without calcium, but we were blunting the effect of coronary calcium by telling them that they had a lot of disease and they better get on more therapy. So it was kind of a self-defeating prophecy. In Heinz-Nixdorf recall study, they were not told what their results were. And it did improve the area under the curve, but more importantly, it reclassified a lot of people. So how many people does it shift? And Dr. O'Leary nicely described this already, but how many people does coronary calcium shift? And the answer is it moved from intermediate risk, it moved 14% of people to high risk, and more importantly, I think, it moved 63% to low risk. What does that mean? 3 out of 4 people tested got put into a different category. We thought they were intermediate risk because they had a couple risk factors, and we were wrong 3/4 of the time. Showing you the limitations of Framingham, but also showing you the potential of doing an imaging study where we can identify subclinical atherosclerosis. They're no longer in that wastebasket of, well, you may or may not develop disease. It's either you're high risk, I need to be aggressive, or you're low risk, we can maintain more lifestyle modifications to try to fix to try to address your issues. So the guidelines currently state that we should measure atherosclerotic burden in clinically selected intermediate risk patients, to refine risk prediction and select patients for altered targets for lipid-lowering therapy. And I think that since 2005, when the AHA said this, the data has only become more and more solid. Almost every study I showed you, except for Dr. Shaw's first paper, was published in either 2005 or thereafter. So this is new data. We haven't even seen the final publication from Heinz-Nixdorf recall study. We've only seen it at the ACC presented. So we're still getting new data. So where does calcium fit into a clinical algorithm? Well, obviously a family history of premature heart disease. You might have had the genetic predisposition that your father or your mother had, or their lifestyle may have been different, predisposing them to coronary disease rather than you. Dr. Blumenthal and others have done really nice work showing us that sibling family history is much more important or much stronger risk than parental, because we're now in the same lifestyle categories. But it's really important to understand that a family history is not even considered a risk factor according to Framingham. If every person in your family died of a coronary event, every single person died of a coronary event at age 40, and you calculate the Framingham risk based on that knowledge, it doesn't change at all. It's not part of the Framingham risk calculator. A potential problem when we talk about significant family histories of coronary events. When you have a moderate cholesterol elevation, obviously if your LDL is 250, you're going to treat that person. And if their LDL is 50, we're more likely not to treat that person. But there's a lot of people, the average LDL in the US is about 130. Average LDL in the US is 130 milligrams per deciliter. That's kind of borderline abnormal. But do we treat every person? Do we put it in the water supply or not? I would favor knowing if they had atherosclerosis, and instead of treating everybody to an LDL of 110, treating some people to an LDL of 70 and others letting them live with an LDL of 130 based on objective evidence of atherosclerosis. So Ernie Schaefer, up until recently and for many years, my entire career, was the editor-in-chief of the journal Atherosclerosis, says the best test for the prediction of the risk of atherosclerosis is the demonstration of atherosclerosis. And I think that's what we're seeing now with both carotid IMT and coronary calcium, that if we want to predict who's going to have an atherosclerotic event, we identify people with subclinical atherosclerosis. And this concept does not start 10 years ago. This concept is not 30 years ago. This concept is 5,000 years old. Here's from 2600 BC. Dr. Hecht was the first person I know who used this slide, and I stole it from him. Superior doctors, I'll let Harvey read the Chinese if he wants, or I'll read the English. Superior doctors prevent the disease. Mediocre doctors treat the disease before it becomes evident, or inferior doctors treat the full-blown disease. And I would say to you as an invasive cardiologist that we've been spending far too much time treating the full-blown disease and not enough time treating the subclinical atherosclerosis. Can we do what Dr. O'Leary aspires to, prevent atherosclerosis from occurring? I don't think we quite yet have the tools or the knowledge exactly how to stop atherosclerosis completely, but I think we can at least move up from inferior doctors to mediocre doctors in the eyes of the ancient Chinese by identifying disease earlier and treating that disease that we find aggressively. So thank you all very much for your attention.